Hi, everybody. My name is Victoria Hensley, and I am a nurse in the emergency department at Riverside Regional. Today, we're going to be talking about trauma-informed care within the emergency department and ways that we can incorporate this in our patient care. Some of the objectives for today are defining what trauma-informed care is, and why that's important. Recognizing a trauma response, the neurobiologic brain, and talking about trauma brain. Recognizing triggers and what we can do to help our patients avoid these. Bessel van der Kolk is the founding father of trauma-informed care. He stated, the big issue for traumatized people is that they don't own themselves anymore. Any loud sound, anybody insulting them, hurting them in any way, saying bad things can hijack them away from themselves. And so what we have learned is that what makes you resilient to trauma is to own yourself fully. So we're going to talk about what trauma is. Trauma is highly subjective. It could be any event that happens. So what one person might consider traumatic might not be traumatic to somebody else. So it's any event that happens that is so deeply distressing to that individual that it causes a stress response that could have a long-lasting impact with that person. And there are multiple different types of trauma. There's physical trauma, emotional trauma, complex trauma, historical, generational trauma. Some of the examples of like physical trauma would be gunshot wounds, stabbing, falling and breaking your leg, anything that physically hurts you. Emotional trauma is like a stress, anxiety, somebody bullying, hurting your feelings, things like that, and that would elicit the same type of response, but due to emotional reasons. When we talk about complex trauma, it's more so long occurring trauma over a longer period of time. So many times when we say complex trauma, we're talking about maybe soldiers that have gone away to war and come back, and they have experienced both the emotional complex trauma over a longer period of time, and that's what we would call that. We also have historical and generational trauma. That would be talking about issues such as slavery and the long-lasting impact that the feelings of the slavery has caused people in our generation now. And then any types of trauma can result in PTSD, which is a condition that develops in response to trauma. So the 6 guiding principles of trauma-informed care is safety, being trustworthy to our patients, so eliciting an environment where they feel that they can trust us. Peer support, collaboration and mutuality, empowerment and choice, so giving the patient the power to, in healthcare, for example, giving them the power to say, yes, I want this exam, or knowing what's going on. Knowledge is power. And then we have cultural, historical, and gender issues. So being cognizant of a patient's identity and how they want to be themselves. That's being able to understand those issues. So why is trauma-informed care important? The most important reason is because so many people in the United States have experienced some sort of trauma. So most of those patients that we have coming in the emergency department, they have experienced trauma, and we might not know what the trauma is that they experience, and they probably are not going to tell us right then and there. But it's important for us to be cognizant of the fact that patients have experienced trauma at some point in their life. There's a scale scorecard that we are planning on placing up at triage to follow the patient around, so that at some point we can discuss these adverse childhood experiences with them, so that we can get a better understanding of what they're going through. The adverse childhood experiences, which is your ACE scale, goes over different areas of abuse, such as domestic violence, substance abuse, mental illness, neglect. The greater the number of ACE that they have experienced, the more likely they are to have long-lasting health impact, depression, anxiety, substance abuse, alcoholism. They just have a lot more long-lasting issues than people with lower ACE scores. So the 4 R's of trauma-informed care. We all have to be be aware that medical care in itself is very traumatizing. We're touching these patients. We're all up in their business. And they're not used to that. Many of them don't like to come for medical treatment because they don't want to experience these things. So the 4 R's of trauma-informed care are: 1, realize the impact of trauma, understand how this could affect them, but they can recover and they can still thrive and do well. And then recognize signs of trauma. Respond, integrate the knowledge of trauma into policies, procedures, and practice. So any policy that we have should be a trauma-informed policy. We want to provide a safe environment for our patients, and being trauma-informed is incorporating these approaches. Resist re-traumatization. So re-traumatization can happen to anybody, anywhere, but especially for our patients. I'm going to bring up an example of a patient that has been sexually assaulted, history of a sexual assault when they were younger. And then something that we do every day to many people is utilize that PureWick for urine collection. So it can be very triggering and traumatizing to a patient, especially one that has had a sexual assault in their history, to approach them with an object that looks similar to something that hurt them and attempt to put them in their private area. Even though, we have our reasons for needing it to prevent urinary tract infections, to minimize the need to do catheters. However, we have to acknowledge the fact that this could be difficult for them, and we need to give them the choice, if they want it or not, or at least talk to them about it so they can understand what's going on and they're not just being touched without their permission. So let's talk about what a trauma response is. And so many people come to us and are having a trauma response, and we might view them as, oh, they're just being difficult, or this guy is really mad, and oh, he's just high again, whatever. But we have to be cognizant of the fact that these are all responses to trauma. This is all a way that a person reacts to something that traumatic that has happened to them, whether it be in their past, something that they're not even thinking about, is subconscious, or something that's acutely happening. So some of the trauma responses are fight, flight, and freeze. So that's your fight or flight. Your body's in that constant state of, oh my God, something bad's going to happen to me. It's classified with hyperarousal. They're constantly ready to run or fight. Either that or they're just frozen. They experience intense emotions. So they may react with anger, guilt, shame, anxiety, fear. And it might not seem rational to anybody else why they're so angry, but to them it is, and we need to validate that. Flashbacks. Many of them have flashbacks to the initial event that caused the trauma, especially if there's something that triggers them. If they're concerned with police officers and they see police officers walking down the hall, perhaps even to go to somebody else's room, that is triggering to them, and they might elicit this trauma response to where they're so worried that this officer is going to come and get them. Or just seeing somebody that reminds them of somebody that hurt them in the past. That's also something that could cause a flashback. Hypervigilance, this is when they're always on the lookout for a threat. They're constantly surveying the area, paranoid, but they're not really. It's just a response to something traumatic that had happened to them. Then we have some physical symptoms that patients have, and they don't even know that the symptoms that they're having are a trauma response. Headaches, not able to sleep at night, the heart's racing, just pain all over their body. Little kids manifest it in belly pain. They complain of their belly hurts constantly, and we try to figure out what could it be. Maybe it's constipated. Maybe it's this and that. And there's nothing going on other than the fact that they're having psychosomatic side effects of something traumatic that happened to them. And then, of course, there's avoidance activities. They do things to try to numb themselves so that they don't have to think about bad things that happened to them in their past. Many of these patients turn to drugs or alcohol, and they come to us as our frequent flyers. Every other day, we're seeing them either drunk or intoxicated on some sort of substance, and we want to be quick to dismiss them as, oh, he's just high again. When in reality, we need to acknowledge that this is a response to something traumatic that happened to them. And until we talk to them about that and until we deal with the issue at hand, it's going to be a recurring cycle. And then we have dissociation, where they just totally shut down. They disengage from the situation, and they won't talk to you at all. So how trauma affects the brain. It's been shown in scans that chronic trauma actually causes changes in the way the brain looks. There's three types of the brain that are considered, to be affected with trauma. You have your prefrontal cortex, which is the part of the brain that is in control of rational thinking. It regulates your emotions, your fear responses. So people that have had trauma, they're not able to think rationally, or what we would consider rationally. Their emotions are all over. They're quick to anger or inappropriate responses to things. The hippocampus, which is responsible for memories, differentiating between past and present. This part of the brain is responsible when a patient is not able to recall all the events that happen. So they might have short-term memory loss, or they just might remember bits and pieces of things at a time. This is something that's pretty common with patients that have had trauma, and we talk about it with law enforcement, where they told you this story and they're telling us something else, but in actuality, it's a response to trauma. People just remember things, bits and pieces, or they might not remember anything at all initially, but then a week down their line, they're remembering stuff and, this happened to me. It's not that they're not trying to tell us what happened. It's because they're having a trauma brain. The amygdala, which is wired for survival, this is the part of the brain that's responsible for fight and flight. This is constantly in overdrive, so it's sending it, and it's been shown to shrink in size, so that's why it's not able to regulate the hormones as it normally would. So it's constantly eliciting all these stress hormones. The body is always on that high alert. And then you have the actual chronic health conditions that develop secondary to always being in this fight or flight, and always having all of these fight or flight hormones like epinephrine running through your system. So the most important thing for us to get out of this today is, what are triggering events? So we want to avoid things that can trigger people, or if we see that something that we're doing is triggering them, try to think of a different way to do it. If a patient does not want to talk to you because you remind them of something bad that happened to them, try to do what you can to, maybe get a coworker to come help them, because it might not seem rational to you, but to them it's real. So what a trigger is a stimuli that reminds people about their trauma, and it leads to these heightened emotions and the hyper physiologic response that patients can experience when they do have a trauma response. So their heart can be racing, they can break out into a sweat, nausea, vomiting, headache, anger out of proportion. So what is triggering to somebody is highly sensitive, highly individualized for each individual person. And it could be sensory in nature, emotional, social, internal. So a certain smell might remind them of something bad that happened to them in the past. When the doctor comes in and goes to listen to their lung sounds, just being touched or the way that they're touched can cause that trigger. Loud sounds, booms. A lot of times soldiers experience this. Hearing a loud sound, fireworks on the 4th of July, that's triggering to them. And then just emotional feelings similar to the way that they felt when this happened. So you'll see this in victims of domestic violence, or husband and wife, when the husband is like a chronic cheater and something happens that triggers that wife to remember how it felt when he was being unfaithful in the past. Even though he might not be right now, the point is that that's something that triggered her to feel the way that she felt when that initial traumatic event happened. And then we have social triggers, which could be just being in a crowd, being in a parade, being around a lot of different people. Confrontational events. So you having an argument with a coworker, we don't know everyone's history and all the events that somebody's been through, but you having an argument with a coworker and speaking to them in a loud tone of voice, that could be triggering for that person. They might shut down or perceive you as a threat, and that would be considered a trigger. And then the actual physiologic internal cues, which would be like elevated heart rate. So a patient feeling their heart racing would remind them of how it felt when their heart raced when they went through a traumatic event. So some of the things that we can do is listen actively. Don't interrupt them when they're talking. Validate their feelings. No judging. And provide a safe environment. To support somebody that's experienced trauma, we want to be supportive. Allow space if they need some space and some time. Give that to them. So if you guys can just give me some feedback down below, I would love to hear any recommendations that you have. Thank you.